Welcome to another exciting episode of the Executive Wellness Unplugged, where we break down complex health issues to empower leaders and others to thrive in life and work. Hello, I'm your host, Lisa Kelly, and I'm here to guide you along with my guest on a journey towards optimal well-being and peak performance. In today's episode, with insights from Dr. Ina Husain, whom I will introduce momentarily, we will address a commonly experienced but often misunderstood condition known as LPR or silent reflux. So I'm leveraging Dr. Husain's expertise and drawing on my own knowledge of and experiences with LPR, both personally and as a holistic nutritionist and certified executive wellness coach. We will attempt to demystify LPR symptoms that often go unnoticed or maybe unaddressed, and most importantly, illuminate remedies or strategies to help manage this condition that affects many of us today, especially busy leaders and executives. So grab your favorite healthy beverage, settle into a comfy chair, unplug from all your distractions, and let's embark on this wellness journey together. By way of introduction, Dr. Ina Husain is a board-certified otolaryngologist and a fellow trained laryngologist. She's currently the medical director of laryngology at Powers Health in Munster, Indiana, where she specializes in, now I hope I say this correctly and you'll probably correct me, laryngopharyngeal reflux. Did I get that right?
You did.
Oh, thank you. And she started her career in academic medicine before transitioning to create the first voice airway swallowing disorders program of Northwest Indiana. And she's an active medical educator on social media with over 270,000 followers, an international speaker, and a published researcher. So, welcome to our podcast.
Thank you so much, Lisa. I'm happy to be here today.
Yeah. And I'm just curious, I'm looking at the voice airway swallowing disorders
Mhm.
program. So did you actually establish that yourself or create it?
So I was recruited by Powers Health to create that program in Northwest Indiana, which was kind of an underserved area for patients with laryngeal complaints and disorders. And so working in collaboration with speech language pathology, we're now able to offer these services locally.
Oh, so that's interesting. So you do as like a multidiscipline approach with the speech
Sure.
pathology. Yeah,
Correct.
that
Yeah.
makes a lot of sense. So to provide context for our listeners, I was first introduced to you via another interview on YouTube, or I think a couple actually I watched.
Mhm.
You can check out more interviews with her on YouTube and elsewhere. And then subsequently on Instagram, where you have quite a presence and an active following, right? And,
Yes, thank you.
and just I wanted to ask you before I forget, do you support people remotely in any way?
So currently I don't offer telemedicine. I just do in person.
Okay, that's good. So, as a sufferer of LPR myself, and I believe you've referenced in social that you experience this as well.
I have, yes.
Yeah, so we're both living, we can walk the
Living
talk.
it.
Yeah, yeah. I was really impressed, I guess, to learn that they're actually specialists in LPR. And so I immediately reached out to you on Instagram to invite you on the show, and you graciously accepted. So here we are. So before we deep dive into, I guess, a really deep discussion on of LPR, can you explain what LPR stands for? And it is short for, the condition we're talking about. And I guess a brief description of the condition and how it may differ, for example, from GERD, or chronic acid reflux.
Sure. So the acronym LPR stands for laryngopharyngeal reflux.
Right.
We also sometimes will call this silent reflux, or you may have heard terminology such as respiratory reflux. And this is
Okay.
really referring to the process of what we call gastroduodenal content. So essentially anything in your stomach that comes out of the stomach into the esophagus. That terminology is called reflux. So when we say laryngopharyngeal reflux, initially we were primarily speaking about that refluxate making its way to what's known as your throat or your upper aerodigestive tract. This is different than GERD or gastroesophageal reflux disease because that is implying that the reflux is affecting the esophagus only. And that can present with typical symptoms of things like heartburn, indigestion, discomfort in the abdomen, which is very different than the symptoms we see with LPR.
Very interesting. And if I can just for a minute, I don't want to make this about me, but I just want
Mhm.
to interject with a personal experience because I went to my doctor recently and it was a telemedicine visit. So maybe she would have asked me more questions, but telemedicine sometimes a little quicker. And I said, I think I'm having GERD attack again, so I probably get a PPI. And so she didn't ask too many questions. She knows I'm pretty in tune with my body. But then I went on subsequent to that, I went because they weren't working. And then I was also
Mhm.
clued in, like, too, when I went away on holidays, like, I didn't have any symptoms and the air was better than where we are and different things. So I started wondering, like, is it really GERD, right?
Right.
Chronic acid reflux. And then I went on some Facebook groups. Like I'm in one Facebook group with 40,000 people, and one of the areas they talk about is LPR. So that was completely
Mhm.
new to me. So I thought, oh, I got to learn more about this. And then I got like Dr. Aviv's book and the acid washer and Dr. Kaufman. I studied her and I started realizing maybe I don't have GERD because I didn't have the typical burning symptoms here. It was more upper throat, right? Now,
Right. Mhm.
and I also want to say that in a recent visit, follow up to my doctor, I said, I don't think I have GERD. I think I had LPR or silent reflux. Well, you wouldn't know she just looked at me like, what? And I said, well, you're not familiar with it. And she's a pretty informed doctor. And
Mhm.
she said, no, she said, there's different kinds of GERD. And she left it at that. Now, I don't want to throw her under the bus or anything, but, maybe this is a good point to ask you, like, why or how is it that not a lot of doctors, because I've watched like people out of Stanford do really impressive presentations on this and yourself and others. How is it that not more primary care physicians know about LPR?
So I agree with you. We're not throwing anybody under the bus here. But if you think about otolaryngology or ENT, we're a very small subset of medicine,
Okay.
right? And so this is very different from the world of like everybody needs a cardiologist, but not everybody needs an ear, nose, and throat doctor. And so I think part of it is just how small of a field we are. The other part that I think makes it challenging to kind of do broad spectrum kind of education on this is that LPR really has been an evolving diagnosis over time. So when it was first kind of when it was first given a name, it was a very different kind of what we call beast than we know of it today. So there's been a lot of growth in the field of LPR and LPR disease. And the definition, to be very frank, has been evolving even during the course of my training. It's very different now, or what I know of it now is incredibly different than what it was even 10 years ago or even 7 years ago. And so it's very difficult to educate accurately and update accordingly for something that is somewhat considered a niche diagnosis,
Mhm.
that there are not a lot of experts in it, and that we're still trying to understand what it really means. And so I think that's one of the challenges. And honestly, it was really the reason I started my social media platform was because of these issues that were arising.
And so there's lots of evidence-based research and studies and peer reviews and everything, I would think, because I've read some on this actual condition, right? So it's not just something that we just pulled out of thin air, right?
No, not at all. I mean, it is a well studied condition. I mean, we are talking basic science all the way up to clinical research and
Right.
clinical trials. And so it does exist. It's just that the world of those who are leading the charge is a little bit smaller because we're in the field of ENT.
And so let's just walk through the physiology just for a second. I don't get too
Mhm.
far into the science, but as I understand it, with GERD, it's typically the acid coming up, right? But with that create is problematic for people. But with LPR, is it what they call the gas or the pepsin that is the activator of the issue? Can you speak to that if I'm saying
Yeah.
that correctly?
So, when you think of what's in your stomach in terms of digestive enzymes, it is not just acid. Acid exists in the stomach, but there are other digestive enzymes such as pepsin, which is technically non acidic, but there's also things like biliary salts. And so when that refluxate comes out of the stomach, that combination of enzymes can cause a lot of damage. And so primarily with GERD, we think of acid as being the primary player in that. But we know that pepsin is also important for things like acid reflux damage, even in the lower esophagus.
Okay.
So, at studies looking at people who are having reflux events to the upper aerodigestive tract or the throat, if we want to simplify, we find that a lot of times the acid doesn't make its way all the way up, whereas the pepsin does. Now, pepsin can act very differently when it gets up to the throat. One of the big studies by Dr. Johnston and her team up in Wisconsin found that this pepsin actually can be taken into the cells of the throat, where it can kind of hide out for up to 3 days, waiting to be reactivated. So it's sneaky. I always call it like the ninja of LPR, right? Like it's there, it's hiding, just waiting to be reactivated. And that's why we think LPR symptoms can actually present delayed from the actual reflux event, whereas with GERD, they can happen then and there. And that's why you feel the heartburn, but the coughing and the throat clearing may start to occur the next morning.
And just again, this probably come up later, but it's activated typically through acid-based substances. Is that correct?
Correct. So an acidic environment is what the terminology we like to use seems to activate pepsin. The problem is that it's very difficult to completely deactivate pepsin,
Oh.
right? So you can kind of be in a less acidic environment, even a neutral environment, and pepsin is not irreversibly deactivated.
Mm.
So let's say the next day you drink something acidic. Well, that pepsin that was in your laryngeal tissue in a somewhat deactivated state can get reactivated. And so this is part of what's so problematic about treating this is it can present delayed, and we don't have that, we don't have excellent testing for it in the throat.
Right. And again, so okay, we're probably going to come back to this, I'm sure, in terms of, um, triggers and symptoms and also remedies. But um, how? Okay, well, let me just ask you this since we've already addressed some. So, what are some more common symptoms of LPR that maybe people don't associate with LPR, aren't familiar with LPR, or even overlook?
Sure. So I think it's really important that we're talking about common symptoms of LPR, but remember, these are non-specific symptoms. And so that's what can make differentiating LPR from other conditions such as allergies so challenging. So I
Right.
always tell my patients or followers on my Instagram platform that symptoms do not make a diagnosis. Right. So we just got to be really careful with how we're diagnosing LPR. But common symptoms, so symptoms we see commonly in patients with LPR, include things like chronic postnasal drip sensation or a mucus sensation in the throat, which can then lead to things like throat clearing. We see recurrent sore throats, coughing, hoarseness, difficulty swallowing. We see all of these in patients with LPR.
So, in the Facebook group, a lot of them talked about the globus. Can you explain what that
Globus sensation.
globus?
Yep. So we use the term globus sensation, and essentially means kind of a foreign body-like sensation. So most commonly, that sensation is like a feeling of a lump in the throat or a ledge when you're
Is
trying
it a
to
feeling,
swallow.
or is there actually something physical there?
So it's primarily a feeling of something physiologically happening. And so globus can be a sign of something like a throat cancer. So then that means something's actually there. But the feeling of a lump can also come from normal anatomy doing normal things. And so most commonly with LPR, the globus sensation is actually you're feeling your own muscles that
Oh,
are tense and tight because
oh,
there's normally muscles there. And so in that case, globus isn't necessarily a foreign body or something that doesn't belong there. But that's why globus is also a non-specific symptom, right? It can be a symptom of things like LPR, but it could also mean something is there that doesn't belong there.
because I got the impression from some, and maybe it's they misinterpreted. It's probably more of a sensation or a muscle, but they actually talked about like waking up in the middle of the night because they felt like something was choking them. So is that maybe the throat closing in, or there's actually typically a physical substance or like phlegm that builds up there, or maybe a combination?
Correct. It can be any of those. And that's why
Okay.
when patients come in and they say, sometimes they'll come to me as a second opinion and say, I have globus.
Mm,
I say, actually, tell me what it is you're feeling without using that term. And
right.
then most often than not, they can actually describe it better than the term globus. They'll say, oh, it feels like a lump. Or they'll say, it feels like mucus or wetness, right? So those are two completely different sensations. And so I like to go take a step back and say, let's actually describe what you're feeling. Let's not use terms right off the bat.
I love that. I love that. And can we, I'm kind of getting ahead of myself, but you did mention cancer. And, of course, anyone with GERD, we're always told by our doctor, go on PPIs because, again, you don't want to get Barrett's esophagus. So, just a form of throat cancer. But, is there a risk as well for people with LPR of getting Barrett's esophagus cancer?
So, what we think about with LPR is that there are different mechanisms of reflux that can lead to kind of subtypes of LPR disease.
Oh,
And
okay.
this is something that's really developing in our field. I often talk to patients about four subtypes of
Mm.
LPR disease. Now, if you have the direct tissue damage version, which means that refluxate, whether it's liquid, solid, or gas, is making its way to the throat, meaning direct contact with your throat tissue, that is a concern for developing things like throat cancer
Okay.
because LPR, the refluxate, including things like pepsin, can be incredibly inflammatory, and inflammation can create an environment in which cells can change. And this has been shown on a microscopic level.
Mm.
Okay. Now, not everyone with LPR disease suffers from it due to direct tissue damage. And this is where it gets a little tricky in terms of are you at risk for throat cancer or not? Because your symptoms may not be occurring due to direct tissue damage.
Interesting. I love how I had never heard that and broken down those for, subtypes, right?
Mhm.
So let's get into, oh, I have so many questions for you. I hope we can do justice in an hour. So, how is LPR typically diagnosed or maybe differentiated from other ENT issues or even allergies? Because I suffer from seasonal allergies. So I'm
Mhm.
like, am I suffering from seasonal allergies? Should I take a nasal spray or my allergy pill or, maybe take a Tums or something that's going to block? I don't know. I never know. I'm just confused.
Yeah, and you're not alone in that. I think even as physicians and providers, we get confused too. And the reason for that confusion is um, there are only so many ways your upper aerodigestive tract can tell you it's not happy. Okay.
Mm,
There aren't a million different ways it can tell you. So it can tell you by the tissue causing discomfort. It can tell you by mucus production and by tension and tightness. But again, that's why we call these non-specific symptoms because allergies can cause it, so can LPR, right? So can an upper respiratory infection. And trying to help distinguish based on symptoms alone can be really challenging.
you have them
So,
going on concurrently, like allergies and LPR, and that must be really because I think that's my case, right? And I don't
yes, they
know.
definitely can. And that's part of the problem is that not only can they happen concurrently, but they can also kind of exacerbate one another,
Right.
right? So if you have an upper respiratory infection, your LPR symptoms are going to get worse, right? If you have an upper respiratory infection, your allergies will get worse. And that inflammation can make you more symptomatic or more sensitive to your LPR events. And so I really take when I treat patients with these type of symptoms, I take a really, it's very important to take a holistic
Yeah.
approach because if I am just focused in on LPR, which I do specialize in, and I'm not addressing your allergies, I'm not doing you justice, right?
Right.
We're not going to move ahead if we're not kind of looking at this holistically and
Yeah.
treating all components.
So are you, if I may ask then, as an ENT and you're specially trained to address allergies as well? So you have that area of expertise or?
So as a board certified otolaryngologist, part of our training is allergy training.
Okay.
Now, I also very much understand my area of expertise versus my limitations and
Right.
upfront limitations. And I find working collaboratively with other subspecialists is the best way I can treat my patients. So I personally will help patients find an allergy diagnosis, but I also have a cohort of allergists I work very closely with to help take the lead on that for patients so that I can focus on, the laryngeal focus and LPR.
Right. And it's great. And if I may ask, do you find that your counterparts um you recognize LPR and are accepting of it, and pretty much?
Yeah, I've been, I was in downtown Chicago for 7 years before moving out to Munster, Indiana, which is actually, frankly speaking, kind of a suburb of Chicago
Oh,
as it
okay.
is. So I've been in this area. And I've been very fortunate to work with colleagues who very much do recognize that LPR exists.
Hmm.
And they have found me. And so it works very nicely to work in such a collaborative
Oh,
environment.
that's wonderful. Because I did, again, not to disparage my doctor, she doesn't know what she doesn't know, I guess, maybe, if I can put it that way. But I asked, should I maybe go get, see an ENT, right? And she said,
Mhm.
well, no, I don't think there'd be much benefit in that. So I'm like, oh, gracious, right? What do I do? I could have pressed harder, and maybe, I don't know, maybe I should, I don't know. But anyway, so who could you say, okay, well, let me just ask you this, and like, in terms of
Mhm.
diagnosing it, is it through differential, or how do you go about it,
Sure.
and what procedures that someone might be interested
Sure.
in, ask about it?
So if you're having ear, nose, and throat complaints, so primarily things like postnasal drip, coughing, throat clearing, sore throat, you should come see an ear, nose, and throat doctor for essentially our procedural physical exam. And the reason this is so important is, again, those symptoms are so nonspecific that it could be anything,
Hmm.
right? So generally what procedural physical exam means is that we're going to look in your nose and your throat with a camera, which is known as a scope. We do this routinely in the office. It is, I've had it done to myself before. I've scoped myself before.
Okay.
I'm very aware that it can be somewhat frightening to say, hey, you're putting a camera where, but it's actually really straightforward
Does it go
and
through
can
the
be
nose
done.
or down through the throat,
Yep.
or?
So I do the flexible scope version, which goes as a flexible camera. It's kind of like a little noodle camera, goes in the nose and then looks at your throat, which is everything above the esophagus and essentially the trachea. So it's just hanging behind the nose, and we can see your larynx, which is the main organ there. We can see the vocal cords, we can see the tissue. And most of us, frankly speaking, can do this pretty efficiently. We have some numbing that we use in the office, and then you can go about your day
So
afterwards.
do
And
most
so,
ENTs have this technology typically in their
yes.
office? Okay.
Yes, most
So it,
ENTs
yeah,
do. So this should be something that's readily available if you have access to an ear, nose, and throat doctor.
right. And then, because I have had like scans or x-rays done on my sinus cavities, but I've never had anything, I don't think specifically. They've done swallowing tests. Like, so I guess there's
Mhm.
a series of tests that, you or others would do, right? To try and,
Right. So in medicine, we always start with the history first, physical exam second, before
right.
we do diagnostic testing like x-rays, because we can often come up with at least a direction in which we think the diagnosis will be based on the examination. And so I'll tell you, I've had patients come into me as a second opinion for I have LPR.
Mm.
And when I go through their nose, I find a sinus infection that wasn't treated. And
Oh,
it
okay.
is not uncommon. So just the other day I was communicating with some of my sinus colleague friends from my former job, and I was like, I think I'm channeling my inner sinus surgeon today because I'm culturing a sinus, right? But it's true. It's like, again, the symptoms can be very nonspecific, and unless you start from the beginning and kind of rule out kind of obvious things that we can see on exam, we don't know it's really LPR. So LPR in the real world, I would say a lot of times is primarily diagnosed by this examination. So patients will come and see a provider, ear, nose, and throat provider, a physician, get a physical exam, get a history, and their clinical suspicion at the end of that visit will probably be something like, I suspect you have LPR. Now, this is a suspicion. It is not truly diagnostic. And it's really important to have that conversation with patients that I think you have LPR based on this, but it's not proof. And so at that junction, there's kind of a couple of different pathways in which patients can go. One is what we call the empiric trial pathway, which means I suspect you have LPR. We're going to try some things to see if you feel better. Classically, that was known as what's called an acid suppression trial with things like proton pump inhibitors.
Okay.
And the reason that existed was primarily we thought that LPR was a disease of that acid touching your throat. Now,
Right.
we've known that that has changed over time, but that empiric trial of acid suppression is still okay to do. Um, and see if things get better. I will tell you in my practice, since I specialize in LPR, I actually do not do that very often
Mm.
anymore because of the understanding of how it might, a lot of times it isn't an acid problem, but because of our limitations of medication options, it's still a valid option for patients to try.
So can I
Um,
ask then how many of your patients that you would potentially put on PPIs would experience any kind of relief or benefit?
Yeah, so my practice is, to be very frank, somewhat biased because most of the time patients come to me after they've already either seen a specialist, including another ear, nose, and throat doctor, or
Right.
they've already been put on a proton pump inhibitor. So in my case, I'm only seeing the people who have failed, right?
Yeah.
Who will
Or
already.
anecdotally, is there any research out there, that suggests?
Yeah.
I've read some, but I don't know how valid it is.
Yeah, there was one study a couple of years ago that said less than 50% of people find relief from use of acid suppression trials. Now, the American Gastroenterology Association actually has some great published guidelines that are actually open access, and you can find them on something called PubMed.gov. But they talk about they call it extralaryngeal reflux, and so that's what the papers are under. But they actually don't recommend an antacid trial in patients with extralaryngeal or LPR symptoms unless they also have traditional GERD symptoms, which
Okay.
are the heartburn. So if you come in to see me and you say, I'm having throat clearing, but I'm also having heartburn and indigestion, proton pump trial kind of
Yeah.
recommended. But
For the
if you
benefit,
come in,
no,
yeah,
so I'm going to say before I forget, for the benefit of our listeners,
yeah,
who are not sure if it's, upper or lower, like, because there's two different esophageal sphincters, right? There's an upper and lower. Maybe we should
there
explain. And then what would they experience for those who are not sure if they're having GERD or LPR type symptoms?
Sure. Just divide it up, I guess, stomach or belly and throat.
Okay.
So if you're having kind of sour stomach, stomach pain, indigestion, maybe some bloating or heartburn, which is the feeling of kind of a burning
Right.
sensation in the
Like put it
chest.
here, right here. Yeah. Yeah.
Yep, we kind of put those in the GERD category.
Right.
Okay. And those are primarily treated by your gastroenterology. That's the subspecialist who is specialized. Now, if you come in and you're like, my throat is hurting, I feel a lump in my throat, or I'm clearing, or I'm hoarse. Those are more ear, nose, and throat symptoms that we associate with LPR.
Right.
Now, people can have both. You can have GERD and you can have LPR, or you can have one or the other.
Mm.
So, when we look at stress and relating to reflux, the data is primarily looking at GERD,
Mm.
not LPR specific. So, it's important to kind of take a step back and say when we're talking about LPR, we're really extrapolating a lot of the data that's available in the GERD literature.
Right.
So, stress can increase GERD or acid reflux because it helps release what's known as gastrin, right? Stress also kind of revs up the system, so it can cause more mechanical reflux as well. Now, the second nuance to this is really important to understand that the vagus nerve, which is the big, long, I think from the Latin word for winding is where we get the
Yeah.
nerve
Yeah.
vagus, gives branches along the way. So what that means is it gives major branches to the throat through the larynx, esophagus, and the stomach. And so it's a parasympathetic nerve that's very important for things like digestion. So when we think of stress and its effects on the vagus nerve, we have to remember that that vagus nerve can then get affected and how it functions gets affected as well, right? So it can affect digestion, it can contribute to reflux. Now, that's one part of how it's contributing to reflux, but we also have to ask the question, well, why do I feel my reflux? Right? So reflux is incredibly common. The act of reflux is actually normal physiology, and we don't call that a disease if you're having reflux events.
Okay.
So why does that turn into a disease or a disorder for patients who then develop recurrent or persistent symptoms?
Right.
That's where we come into the idea of laryngeal hypersensitivity. Okay, so the vagus nerve gives branches that give sensation to the throat. And so if that's affected, the downward effect is the larynx or the sensitivity or what you feel in the larynx gets altered as well. Okay, stress is also known to contribute because it can cause what we call hypervigilance. when you are stressed out, your body is more aware of what's happening, and that includes feelings inside the throat. So, globus or the lump sensation is kind of similar to the idea of tinnitus or ringing in the ears.
Oh,
I
okay.
always tell patients if you listen for ringing, you will hear it. Okay, everybody does. So,
Right.
same thing. If you feel the lump and you focus on the lump, the feeling gets stronger. It's a protective mechanism.
Okay.
Okay? And so we think LPR has associated hypervigilance as well as hypersensitivity through the vagus nerve, which is modulated by stress.
Right. Get that buildup and that, is there that mucus buildup to protect an irritation, inflammation of the
It is
throat area?
so mucus is considered protective, actually.
Okay.
So at normal physiology is a liter and a half of mucus and secretions are produced by your nose and throat. And
Oh,
that's
can you say that again, please? That's
yeah.
interesting.
So normal physiology is that a liter to a liter and a half of mucus and secretions are normally produced by your nose and throat.
A
Okay.
liter to a liter and a half. That's just normal. Oh,
Yes, that
okay.
is just normal, but it is slowly occurring. You are constantly swallowing it, and so we don't notice it. So mucus actually has a physiological function. It's a protectant of the lining, it's a lubricant for the lining, and it has some antibacterial type of properties. And it's a filtrant. So when you breathe in air through your nose, it helps filter it before it gets to your sensitive lungs.
Okay.
So mucus, you cannot get rid of it. Okay, we cannot turn it off, and we
Oh,
do not want to turn it off.
okay.
Our goals with patients are to one, figure out is there a reason for excess production? So that would be your signs of irritation and inflammation. Mucus gets overproduced to try to help and protect the lining again. Or is it a case of sensation? Like it's not actually being overproduced, you're just feeling it.
Or could it
And we
be
see that a
thicker,
lot.
maybe? Could it be thicker necessarily?
Correct. So that's might be why you're feeling it,
Right.
right? Because it's kind of been dehydrated, it's thicker now, it's sticking to things, it's not clearing quickly. And so that can give the discomfort that excess mucus
Or
can give.
when I find it throat clearing, I know we can talk about that in a second, but I gotta like use a tissue to get rid of it, and it's thicker than maybe what you're suggesting other people might experience. So maybe that's a good segue then to into the topic of throat clearing, because I know I've
Mhm.
watched you on Instagram say
Yeah.
you don't recommend throat clearing. So let's just tie all this together with a red bow and you know.
Sure. Okay, so what is throat clearing? So when we think about what's actually happening, throat clearing is where you are engaging your vocal cords to slam together to generate a pull to pull mucus up and out so you can spit it out or then
The
re-swallow
up
it.
being
So
it's here and as
correct.
opposed to here,
In
it's
the
coming
throat.
up.
It's in the throat. Yep, in the middle of the throat. And so if you think about that, the sound of the throat clear is those vocal cords slamming up against each other.
Like
Vocal cords,
really trying to bring it.
right, do not want to be slammed up against each other. They're incredibly thin tissue that you have, very sensitive area. And so the act of throat clearing or slamming those vocal cords together violently is incredibly irritating, traumatic, and can be inflammatory for those tissues. So now what you've created is you voluntarily created a source of irritation, trauma, and inflammation that those vocal folds need to protect you against.
And
The way they
you're kind of exacerbating the situation, I would think then maybe,
correct.
right? Yeah.
So now those same vocal folds need to produce mucus to protect themselves against what you are doing. The problem is the vocal fold where that mucus is, you can't swallow that now because that's where you breathe from. So the only way you're going to feel relief is to get that off the vocal folds, which means slamming them again. And so this is why people who throat clear continue to throat clear, right? So unless you can directly address that mucus, unless the additional irritation such as a cold goes away, patients get stuck in this pattern of chronic throat clearing that
And it
they
becomes very
never
habitual, even if you probably don't need a throat clear. It's just a habitual thing because I experienced that, right?
right. And remember, when tissue is traumatized, it's sensitive, right? So I always give the analogy of a poor guard dog who is being kind of yelled at constantly by their owner. That dog is going to look for every single rabbit, squirrel, bushes moving, and it's going to start barking. And
Mhm.
that's what your vocal folds start doing. That, like, the throat clear kind of sensitizes them to things. And then guess what happens? You eat a little crumbly cookie. You smell someone's strong perfume. The temperature outside changes, and now the throat clearing gets activated again. And so that's why we call it a cycle.
Interesting. And I just, took a sip of water and I noticed it's cold. Now, we'll get into this in a second, but while it
Mhm.
comes to me, um, are you one of those proponent for drinking more room temperature water versus cold water? Because I
And
realize my water is quite cold and I normally drink at room temperature. So anything
so
that,
I'm a room temperature proponent, and that's primarily because of my own personal history and symptoms with cold water. So cold is definitely a trigger for what we call laryngeal hypersensitivity. So
oh,
patients will
interesting.
often feel cold weather, cold temperatures, cold ice water can trigger stuff. Now, cold can also trigger things like esophageal spasms. So if you've ever had like a really cold slushy type of feeling where it's slowly going down, people can start to feel a little bit of that chest tightness. There was an incredibly viral video I had made without, to be frank, it was a very quick kind of sharing a story about cold that went very viral on Instagram about a gentleman who was going into what's called AFib. It's a heart rate condition whenever
Mm,
he would drink ice cold water. I
wow.
actually spoke to him after this video went incredibly viral. He found me and we communicated about his story. And so part of that is the relationship between the esophagus and the heart, right? So the heart and the esophagus make contact. And so his condition was being triggered by that ice water activating the receptors in the heart. Now, this not meant to be fear mongering,
Yeah,
right?
not
He
typically.
also
Yeah.
had, there's conditions that can predispose to that, but that was just an example of, cold water causing symptoms. Now, what's tricky about this is cold water is also, or drinking cold or being in cold is also often thought of a way to like reset your vagus system or vagus nerve system,
Okay.
right? So people talk about the water baths.
Right.
When I talk about it, I'm specifically talking about it about the throat lining. So I
Right.
usually recommend if patients are coming to see me with hypersensitivity or these symptoms, I usually recommend sticking to like more room temperature.
Right.
Um, Drinks as just a more natural thing to try, but that's the reason why.
And then I'm also a singer part-time with my husband. We do gigs and
Oh, nice.
like throat clearing is always a real issue. And then of course I get a little nervous, so I think that just exacerbates it, right? But I remember Barbara Streisand or something said, or someone said she would always have a warm beverage when she was singing. And I kind of get that, right? So I'm probably not doing myself like a cold beer is probably not a good recommendation for singing, right?
No, not at all.
Although my
And
husband would swear otherwise, right?
what's interesting about the warm beverages is it's the warmth,
Yeah,
right? So you'll see a lot of things about teas and this fancy tea. And yes, there are some potential health benefits, but the real benefit for your voice and your larynx is actually the warmth. It's
right,
basically think of it as a muscle stretch. The
right.
warmth helps loosen and stretch those muscles so that you can perform better.
Interesting. And on that note, because as I said, I'm talking about singing, and it's a little bit of a random thought or question maybe, but my voice coach would recommend taking. Now this gets into a real controversial topic, maybe the whole apple cider vinegar, and with a
Mhm.
bit of honey and water, and she said that will loosen things up and clear. Now, we're going to get into the topic around strategies in a minute, but like any thoughts around the whole ACV,
Yeah.
remedy for
I,
LPR
I
or yeah,
frankly speaking, I am not a fan of apple cider vinegar simply due to
well, you
how
heard it here, guys, because there's so much controversial information on AC.
right. And again, I'm speaking from the viewpoint of being a laryngologist,
Right,
right? So, in terms of apple cider vinegar, even diluted, I mean, it can be very acidic. And we just talked about people with LPR, a subset have pepsin that's hiding out, waiting to be activated by that first sip. And so, apple cider vinegar is a big no-no in my practice. Now, there are, the proponents of apple cider vinegar for reflux say the reason it helps is because acid in the stomach is one of the things that help tighten your lower esophageal sphincter. So the idea is that if you have low acid in the stomach, maybe you're having reflux because of that. That is an incredibly small subset of people with reflux.
Okay.
Okay. And that's primarily in people who've been taking acid suppression for a really long time, or people who've had really big illnesses or
And maybe
critically
the
ill.
betaine hydrochloride pills might fall under the same category here too.
Right. So I'm very, very cautious because that's a very small set of people. Now, again, I'm not a
Right.
gastroenterologist, right? And so putting in context, if I'm speaking on behalf of being a throat doctor and
Mhm.
specialist, so for my subset of patients, I do not recommend, apple cider vinegar and acid, supplementation in that way. I really would recommend finding out the root cause of why you're having these reflux episodes and then kind of customizing the recommendations for that.
Nice, thank you. Very well said. And you're doing excellent, by the way. I mean, you're
Thank you.
you're very gifted at distilling this information. It can
Thank
be
you.
very technical, and so I want to just shout out that. So another question I had. So can esophageal sphincters? We said there's an upper and lower, correct?
Correct.
Can
Mhm.
through what we're going to talk about momentarily, maybe some strategies, can they regain muscle strength or once? Because let me put it another way. Once you have LPR, do you always have LPR?
Right. So that's kind of, I guess, two questions
Yes.
that kind of a little bit separate answers. So once you have LPR, do you always have LPR? And the answer is no.
Okay.
So the way we talk about it is reflux events can vary, right? So let's say you are sick. Let's say you have gained some weight. Let's say you are on some antibiotics that's messing with your gut health. You're more likely to have reflux events, but those events can go away when that initial root cause or trigger went away. So LPR events and even kind of the disorder can go away depending on what the root cause is.
Mm.
Now, if you have other issues, let's say a lot of what's called esophageal dysmotility or a hiatal hernia,
Mm.
then that's a lot harder to get rid of because we're not directly getting rid of that underlying problem just by necessarily adjusting diet. So that's why, that's why it's really important to figure out why you have
Mm.
it because it's very hard for anyone to provide any sort of counseling or prognostic information because symptoms, again, are so nonspecific. We don't know why you're having reflux.
So someone with a hiatal hernia could that could be a contributor to LPR. Well,
Oh,
certainly GERD.
100%,
Yeah.
right? So anything that contributes to mechanical reflux can contribute to LPR.
Okay.
Now, taking one step a little bit more nuanced here, a lot of people have reflux, but not everyone has the
Yeah, I was going to
symptoms,
ask that, right? Yeah.
right? So there has to be, so kind of the way I describe it to patients, there has to be a second hit here.
Mm.
And that's either going to be the vagal nerve hypersensitivity that is either developed primarily from something like a bad infection or from continued inflammation or something else with your lining. And this is an area of emerging research.
Mm.
What differentiates the mucosal protective mechanisms of someone with LPRD versus someone who's just feeling the GERD and not anything in the
Oh,
throat?
interesting.
So, are there differences in the microbiome of the throat? Most likely. Are there differences in kind of the way your stress proteins are activated, the strength of those proteins? Probably. We have some data that supports that. So, there has to be a two-step,
Right.
right? There has to be two-step. And that's kind of an area of emerging research in LPR
Good.
diagnosis as well as treatment is that right now we're focusing on trying to stop mechanical reflux. But what can we do about your tissue itself to
Right.
help?
And then, just because we're going to get to the thing around muscle strength and regaining that once this
Mhm.
weekend, but that's my part two of that question. But things like people, you talk about well, the gut biome, but microbiome
Yep.
of the throat, like can probiotics help the same, throat as they would a stomach?
Right. So that's part of I guess where I'm hinting a little bit here in terms of emerging data is that
Okay.
we know that microbiome affects a lot of systems, right? There's a lot
Yeah.
of data on its relationship to even Parkinson's, right? Like the
Yes.
gut-brain axis and things like that. So the larynx is part of all of that digestive health too, in a way, and the airway. And so the microbiome of that very much is likely playing a role. And yes, that does open up the idea of then, is there a way to adjust that microbiome to make you less susceptible? And I think that's definitely a potential pathway that we're going to see develop in the next few years when more research comes out, as an avenue in which to address LPR symptoms.
Nice. And then I'm going to get to the muscle strength
Mhm.
in just a second, but I want to stay on this topic for a second. So like things like kombucha, like I find kombucha very almost acidic, like because it's a very strong fermentation. So
Yeah.
again, I'm just singling out a product here, but could that potentially be, to your knowledge, harmful or damaging to someone with LPR?
Yeah, so I'm very, very protective against patients drinking things that are acidic. I
Okay.
find it's a huge
Because we think
trigger for
kombucha is
Laryngopharyngeal.
good. It's got probiotics, but
Yeah, so we always have to say good for what,
right.
right? Good for your gut health, good for what? Unfortunately, if you're seeing a laryngologist such as myself, my primary focus for you is your throat or your larynx.
And would you
And
ask questions related to their diet as well and foods like that?
so we do. So when I see patients for suspected LPR, we do discuss diet. Now, I'm a medical physician surgeon first, and so if I feel like this is a really an area where we can hone in on after my initial kind of guidance, I actually plug patients into gut health dietitians because again, knowing my own limitations, but also understanding that there's a world of, medicine and healthcare out there that I am not a specialist in, but hey, I've reached out and made contacts because I think that is important for my patients. And
Right.
so kind of hand you over to kind of an expert in that
Yeah.
field, which would be a gut health dietitian to take it from where my limitations are, but to help you.
Yeah. And so coming to the other question then, like once that maybe I hope I'm phrasing this correctly, but once the muscle strength is weakened of your upper or lower esophageal sphincters, can you regain that tone, that muscle strength
Yeah.
again?
So I have not seen any convincing data that you can,
Okay.
really, frankly speaking. So
All is not a lost
um,
cause or hopeless.
right. So, and the thing about that is that permanent muscle weakness is different than intermittent. Okay.
Okay.
So, how these sphincters work, there are a lot of factors that relate to how the sphincter works. It is an active muscle.
Hmm.
And so, again, we had initially talked about the level of acid in your stomach controlling its contraction. Weight, pressure on the sphincter can cause it to not be able to squeeze as tight. So, that's a modifiable effect. Now, are there conditions where the muscle itself gets damaged? There are, but primarily those are the opposite of reflux. Those are too tight muscles that can develop. So there are primarily muscle problems that can develop. In terms of the literature and supporting like strengthening the muscle for the lower esophageal sphincter, there are some smaller studies that show things like diaphragmatic breathing can
Hmm.
be helpful,
Hmm.
which is also known as belly breathing, which is
Right.
actually also helpful for the vagus nerve.
Yeah.
But there are some studies that show that that likely kind of helps strengthen. These are very small studies,
Yeah.
right? So to generalize based on that would not be appropriate. But if patients are looking for natural things that are not really harmful that they can try, I usually discuss diaphragmatic breathing or belly breathing with patients. A couple of years ago, there was a device that was on the market for strengthening your upper esophageal sphincter tone, that had some, again, smaller studies showing some improvement. And most recently, there's been a new device that has been kind of been studied to kind of see if we can tense or tighten that upper esophageal sphincter. What's so complicated about this, though, is that if you overshoot and you strengthen it too much, then we have problems swallowing.
Right. Yeah, that stands for. And so that brings me to another question around exercise, because when I had a flare up last spring, I was doing this 60-day challenge at the gym, right? And a lot of
Uh-huh.
ab exercise, a lot of elliptical
Yeah.
up and down. And, and I wondered, and I've been reading, like they say with GERD or LPR, maybe to really moderate your exercise and don't do anything too intense. Is there some validity to that?
Yeah. So again, it goes back to take a step back and say, we're not talking about necessarily LPR, we're talking about reflux. So
Okay.
that process. So yes, so stomach like crunches, things that are putting pressure, bearing down, those are things that will cause more stomach mechanical movement upwards. And so again, when we talk about LPR, we're really trying to address the reflux events.
Right.
So we're trying to reduce mechanical movement and certain exercises, positioning, can trigger more upward movement.
Like even sometimes when I bend over, I can feel that pressure and maybe the acid comes up, you know. And so again, it's just being very body aware, I guess, and which I'm trying to be, right?
Right. And so sometimes in my office, I have diagrams and I have
Mm,
pictures because I wouldn't expect a patient to understand true anatomy,
yeah,
right? Why would you ever, especially with the throat, why would you ever
yeah,
know the anatomy of that?
yeah.
And so same with reflux, just important to get the sense of the anatomy of the system.
Right, absolutely. So let's just, in the remaining minutes, 'cause I'm sure our listeners are really anxious. So what are some other strategies? And I'm going to throw in some things, you can speak to it, personally and
Mhm.
of course professionally, and I'll throw in some. So what are some strategies for mitigating symptoms of LPR? And also, maybe throw in GERD there as well, because
Yep.
might as well
Yep.
go hand
So
in hand, right?
reflux. How do we try to help a reflux? And
Yeah.
so obviously taking a look at your diet and lifestyle is important, right? So acidic things, we've been talking a lot about
Yeah.
acid, can definitely contribute. Carbonation, the sparkling water. So carbonation is a huge thing that can cause LPR symptoms. Caffeine,
Diet Coke.
caffeine can
Yeah.
weaken that lower esophageal sphincter, right? Causing more mechanical reflux. Portion size. So the more distended your stomach is, the more likely things are to come up and out. Laying down after eating, you need to give your most average people need at least 2 to 3 hours for that
Mhm.
digestion process. If you have any sort of slowing phenomenon, such as gastroparesis, you might need more hours, but mechanical reflux,
Which
again, is a
again
big
is why
one.
we say to refrain from eating 3 to 4 hours before bedtime, right?
Correct. To give yourself time for that stomach to start to clear itself, so it's less likely to kind of move upwards. Alcohol, smoking, all of those things are known contributors to kind of that reflux we were talking about. Now, if just following those natural precautions isn't enough, then my next step is usually something what are known as alginates. So
Mm.
alginates are made of algae or seaweed.
Like
These are
Gaviscon
these
would
are
be an
also
example. Yeah.
Yep. So the Gaviscon, it's very important to understand that we're talking about the European Gaviscon,
Oh.
not the one found in the US. So
Now
the
in Canada
Gaviscon
here, it doesn't have alginates listed on my, so I don't know if maybe I got one similar to the European.
you might, yeah, you might have the European. So the European one is the key, the one that has been studied.
Mm.
I talk a lot on my online platforms about one here found in the US called Reflux Wrapped.
Yes.
I do a bit of education for them, and it's been specially formulated to try to reduce that upward movement. Now, also important to understand that alginates do not cure your underlying root cause, but they're used as a supplement in your pathway or in your journey.
Right.
Um, Other than that, we've talked a little bit about the use of acid suppression. Again, if you do not have traditional reflux or GERD symptoms, they seem to be less effective for that. But it's something that exists on the market and is often tried. And then in the future, there is a potential antipepsin medication that's kind of going
Oh,
to be going through clinical trials soon. That is a different pathway or a different treatment option. So it's something exciting that's coming up for those of us who are very excited about LPR.
right.
I'm
Exactly.
excited to see where that goes, but that might be another kind of treatment option for patients.
Yeah, well, that's great. And you've ticked off a lot that I had here on my own little personal list. But if I may share, and you can maybe share what
Of
works for you if
course.
you want. I find what works for me is alkaline water. I've heard a lot about that because it's
Mhm.
helps neutralize, I guess, the acid or creates more alkaline environment. Is that correct in the throat?
So there was one study looking at the use of alkaline water, and the alkalinity had to be 8.8. So if you're
Right.
going to do alkaline water, check what the actual pH of
Yeah,
it
I
is.
actually have a picture that's specifically for that, and I have to say it's really helping. Or the flow water or whatever you call it in the States. I don't know what they call it down there. The smart waters and that, right? That
There's actually, I'm going to give a shout out. There's actually a company called Alkinator. I believe they're in Canada.
Okay.
So that way we're a little bit more friendly for the environment in
Yeah.
terms of bottled water.
Yeah.
So it can alkalize the water from your sink or
Okay,
tap.
nice, nice. And then also I find like chewing gum or like those little ginger chews, like the chewing gum. What is it about gum chewing? And of course, we want to do a non-mint because mint can,
Irritate. Yep. So
irritate, right?
it encourages saliva production, and saliva naturally has bicarbonate in it. So it's
Right.
considered, so that's why sometimes people who have excess saliva, that's actually a symptom of reflux because your body's trying to protect you, right? So you're making more saliva against that reflux. So chewing gum is thought to help with creating saliva
Yeah,
to be a natural antacid.
it really works for me. I don't know about you. And I use the pure brand with the bubblegum flavor because there's no mint in it.
Sure.
You don't want to.
Yep. And it also encourages swallowing. And so
Oh,
swallowing can bring the reflux down because you're
nice.
pushing it back into the stomach.
Right. And then it just things like I grate up ginger and have ginger tea at night. And it's a nice way too. And, as a side note, it's just something, if I'm really hungry, I'll have a piece of fruit, just something very light or a couple little nuts, but nothing heavy because we don't want to eat anything heavy going to bed, right? Which is hard for people because that's when we snack,
Hmm.
right? It's nighttime.
Right.
But it's a learned habit and I work with clients on that. But, breaking down our meals, as you said, I even use a little baby plate as opposed to a big plate. And this
Mhm.
is going to sound really silly, but what helps me is I cut my food up almost in baby pieces, like I'm feeding a child. But it really forces me, and I teach mindful eating in my courses and to people I coach.
Right.
Really forces me to eat slowly and mindfully because our tummy doesn't have teeth, right? You know this, and we know this. So we got to really make sure that, and most of the digestion starts is activated on our tongue, as you
Right.
will know.
And remember the stomach, yep, and the stomach is delayed in realizing what's happening to it. So if
Yeah.
you're eating fast, it won't know it's full until it's kind of too late.
Yeah, and then we get yeah. I think that was actually I remember one night we had I don't eat pizza a lot because I do dairy free and it's not that exciting, but I have it with my husband. So I ate some. He made a really good pizza one night, and I overate, and oh man, it was the start of my flare up, And I've been 6 months
Yeah.
later still trying to address it, right? But yeah, I won't do that again. Sleeping on the left side that's made a
Mhm.
huge difference for me. And again, you want to quickly, if we have another minute, can explain that why?
Yeah, you want to bring your stomach down. So it's gravity. So either raising the head of the bed, kind of like a ramp or
Yeah,
a
I had a
wedge
wedge
pillow.
pillow I got from Amazon,
Mhm.
really worked well.
Yeah, or left side down, which keeps the stomach down.
Yeah, yeah. Now I got away from the wedge pillow. Now I just sleep on my left side. But I tell you, if I lie on my back, I feel it. So
Hmm.
just a little tip there. There's something to that. Take more mini vacations. When we talk about the vagus nerve and stress, like, man, we can all use that. Keeping our posture upright, right?
Hmm.
There's something to that as well, because when we collapse, right?
Right. It can cause more mechanical reflux.
Right, absolutely. Yeah, that's a few things that really work for me. Without question, the gum chewing, the alkalinity water really helps with slowing down my eating, smaller portions. Which is always a good thing. Anything else? Anything personally before we wrap up here that anything else you want
Yeah,
to?
I think that's a great overview. For me personally, I found that the acidic drinks were a huge trigger. So I haven't had orange juice in a decade,
Yeah, well,
honestly.
even orange, I tried
Yeah,
one
it's
today.
very acidic.
I still can't do it.
And the carbonated beverages are a big one too. We see a lot, especially in the summer months, like
Yeah,
even sparkling water.
yeah.
But again, finding out your triggers, I think it's important to put the effort into doing that because you can really customize what you're doing.
Absolutely. Well, this is great. I'll give you another, half a minute. Is there anything else, emerging or anything else that we haven't shared or discussed that is important to share at this point?
Yeah, I think the last thing that I would just say is that, if you're out there and you're suffering with these kind of symptoms, I know it can be incredibly overwhelming and you might feel like you're going around in circles. I would highly recommend looking for what's called a laryngologist. Usually they're associated with kind of voice programs. It's kind of maybe being your point person. Social media is not necessarily the recommended place to get medical advice, but definitely I know my platform, I try really hard to provide evidence-based education that you
Yeah.
can then take to your healthcare professionals,
Right.
and kind of start that conversation and just kind of advocate for yourself.
Well, I'll be definitely using maybe a little bit self-serving interviewing you here today, but certainly a topic that needs to be addressed, right? And I just thank you. And I've followed a lot, but I've even learned something new, and I've been really studying this topic. So, kudos to you, right? So, as we conclude our discussion of LPR, and maybe GERD as well, it's really crucial to remember that, being informed, as you probably just said, is the first step towards our better health, right? And while LPR is becoming increasingly common, it can have significant implications. I'm sure you'd agree if left unchecked, right? So we've covered many practical strategies here today, but it's really important to approach and advocate for your health, and really, on a personalized strategy approach. So if you suspect, as she just said, if you have LPR GERD, certainly reach out to I guess maybe initially your primary care physician and then really advocate for yourself too, because you won't always get that immediate recommendation. Advocate for yourself, right? To go see a specialist
100%.
ENT or if you have one in your area, the laryngo,
Laryngologist.
laryngo. Still having problems with that. Um, so thank you. This is
Of
really,
course.
you've covered a lot in an hour, and I hope you don't mind me interjecting periodically, but I'm just so passionate and fired up about this topic personally and to support the clients I work with as an executive wellness coach, right? So thank you. Really thank you
No,
for.
of course. If we can help even one person,
Oh,
it's
I'm sure we'll help many
amazing.
more. Let's hope to see if we can get this interview going viral as well, or what I call viral. And anyway, but and thank you to our listeners as always for tuning into our podcast series. And you're what helps keep this going, right? And so be sure to subscribe, share our podcast episodes, especially this one, with others who may benefit from it. And be watching for next month's episode wherever you listen to your favorite podcast, or you can find us on YouTube, on Spotify, Amazon, Apple, and also, or you can go to our website, workplacewellnesscoe.com, and we'll have the episode there as well. And so, thank you again. Thank you
Of
to our
course.
listeners. And until next time, stay healthy and well, and keep on keeping it real. Bye for now. Take care.